Welcome. I really didn't expect too many this afternoon. The clouds parted and it's a beautiful day. It's up in the 60s, I guess, now. So, but this is number 4. And two things. One, I'm armed with a cursor. So I don't have to say top right, bottom left, or I can actually put the cursor on what I'm talking about. So that's, it doesn't sound like much, but it actually is. And about those essays, some of those have been in the late report. Some of them go back 2 or 3 years, but they're relevant for the next 2. This whole program, this is the last of the kind of foundational material. Then we really get into the nitty gritty with the next one on consciousness and the brain, and then the last one will be a bit of a surprise to you and probably me as I think about it. But I think you'll find it quite interesting. Anyway, so welcome to this. Now this is about, last week was about motor system, the upper motor neuron system in the brain and brain stem, and now this is the sensory side of that. So. But before we get to that, there are a couple of things. It wasn't frozen before, but it is now. Yeah, let's see. Oh, there we are. Well, where would I be without Jennifer Dudna here? And I'm just going to move along here because I don't usually push books, but some of you, I just got my copy a few days ago, a code breaker. So it's ISAACSON's take on not just what Jennifer did, but who got the Nobel Prize last year for her work on gene editing, but about the whole controversy, the ethics issues, but also the competitiveness. And so I think that, and he's a very good writer, but it's a very different write when he writes about Einstein, whom he never knew, and essentially was dealing with archive material. And here's a living, breathing person. Now he's done that before with a few, but anyway, the code breaker is very, very good. And then I rediscovered that one that he'd written, The Innovators. And why did I get turned on this time? There's a wonderful chapter in there on the beginnings of the internet. Who were the players? What were they thinking about? What was important to them? And it's all very germane now in the kind of post-Trump era. So, and then another one that is an abiding interest of mine, Eric Kirschenbaum on, well, now here we are, I can actually identify it, The Zoologist's Guide to the Galaxy. It's a wonderful dad. He's a Cambridge prof. And people have been speculating for a long time about life elsewhere and what shape it would take if it did develop elsewhere. But I think that book needs to be taken together with Charles Cockle's book, The Equation of Life. Both people believe that, listen, the laws of chemistry and physics are going to be the same anywhere in the universe, and therefore the biological solutions will probably look very similar elsewhere if life should emerge. So those are my book things. Now, the reason why I put this up, this is the evolutionary tree for elephants and woolly mammoths. And this is not to talk about them so much as the triumph, the technical triumph of this, because, tracing ancient DNA is a tricky business because DNA is very fragile. It doesn't do well in heat and moisture. And it's been a real challenge for people. But here, they've been able to come up with not the whole genome, but a pretty good sample of the genome as far back as 700, 800,000 years. So why is that an issue? Because that's when modern humans really began in Africa. So that might have been a million years ago to say 700,000 years ago. So so it's interesting that those two evolutionary templates overlap with one another. Now, here we are into the system. Now, these are Penfield maps. We looked at the one on your right here is the, now I should say a word. I didn't say anything about how Penfield did this stuff. It was actually, I mean, it was amazing, his observations, but technically pretty crude stuff. He had used alternating current. He didn't actually measure the intensity of the current very, very often. And so it's really a little uncertain how far the current spread. So just how messy was this homunculus that he came up with. It certainly doesn't have the elegance of recording from sensory neurons, where you're quite certain about what the localization is and what the map is. But still, look at that, well over 2/3 of that is the articulatory muscles, the muscles of speech, of oral speech, the facial muscles, perioral muscles, the tongue, the soft palate, the oral pharynx, and the larynx. All those muscle groups all have to be coordinated. And so a lot of real estate, as one of you said, that's a good term actually, devoted in the neocortex to those, at least to that need. And then of course the hand. And no surprise, the thumb more than the fingers, but boy, look at that compared to the trunk and the leg. Now on the sensory side, over here, it's almost the mirror image. It isn't quite, but still, that allocation of resources to the face, the oral musculature, the skin, the lips especially, and all of that, all of those tissues that we talked about with respect to articulatory speech. But notice the hand and the arm, although the trunk and the leg are certainly disproportionately small, the hand isn't as large as it is on the motor side. I think that has something to do with Penfield's methods. You know, once he came up with this stuff, it was reproduced in textbook after textbook after textbook, and almost became enshrined. So now here's a little more modern rendition of that. And I rather like the body down here, the kind of the huge hands here, huge nose and tongue. Now this is a sensory map here. Now one of the nice things it does take note, as Penfield didn't or couldn't at the time, that primary sensory cortex, that blue, yellow, light, dark blue, what is it? Well, light yellow and light blue, and then green and dark green. That really reflects the sensory system that's projecting to the cortex. And the dark blue, the immediate neighbor to the motor cortex, is not the skin. They're not skin receptors. These are muscle receptors projecting directly to the motor neurons. In fact, I'll mention this later. There's a transcortical reflex. So if you stretch a muscle, if I tapped say one of my tendons and I had a tendon reflex, and say did my knee, there's actually a loop through the cortex that people don't appreciate. So in fact, there are 2 or 3 loops, one through the brainstem and one through the sensory motor cortex. So let's just move along. Now, this is a striking thing. This is 2-point discrimination, the ability to discriminate 2 light touches on your skin as either 2 points, 2 discrete points, or you really can't tell. And now if you look at the top here, the fingers here and the thumb, that kind of thing, it looks like the ability is around 2 or 3 millimeters, that you can discriminate points as close together as 2 or 3 millimeters. Actually, I was checking myself out this morning, And I'm sure you and I are probably close to 1 to 2 millimeters. All right. Now, these receptors, we're going to talk about it in just a second, but they follow those fingerprints, the contour of your fingerprints, the ridges, and then the little the depths between those ridges. A lot of these receptors are either based right at the bottom or near the top. So we'll see that. And very sensitive touch receptors. Now, but look at that. Boy, you don't have to move far into the forearm or the proximal arm, or the shoulder, and into the trunk where even stimuli as far apart as 20, 30, even 50 millimeters might still be reported as 1. So the spatial discrimination is really quite crude over much of the body surface, but not the lips, not kind of around the face, the perioral area, and not the flexor tips, not the whole hand, the flexor tips of our fingers. That's where most of these discrete sensory receptors are. Now, just a word about some of the way this stuff is wired. Here we have, there's a finger here, and one of them here is one of these touch pressure receptors. That's the red one here, and it goes right up to the dorsal root ganglion. It's a collection of primary sensory cells here, and then it goes up the back of the spinal cord up to the brain, crosses over around the lower brainstem and to the contralateral sensory cortex. Then there's another nerve fiber here. It happens to be one that's sensitive to temperature and pain, and they're almost all naked endings here with pain receptors and thermal receptors. And it crosses over to the other side within 1 or 2 segments of where it enters the spinal cord, it crosses over to the other side. So if, for example, there was a lesion on this side of the spinal cord here, it would interrupt position sense, touch pressure sensation, vibration sense, all on that same side. And if it happened to affect this area of the spinal cord, weakness on that side. But the sensory loss would be on the other side. So that we've already mentioned that in a previous talk. So now there are a few pictures in this to remember. Here's one of them. So there's the skin at the top. There's those ridges, skin ridges. Just think of that in the tips of my fingers, or look at your thumb. And there are 2 types of receptors that are just below the surface. One of these kind of Merkel discs. Now these are named after the person who discovered them or actually reported them, anatomist. But anyway, there's a little receptor right at the bottom there. These are Merkel's discs. These sensory receptors have very small fields, maybe 2-3 millimeters max. That's why you can discriminate objects as close together as 2 or 3 millimeters. And then there are these these Meissner's corpuscles, which are higher up. And they also have a similar field that's quite small. In other words, you almost have to be right in the immediate vicinity for this receptor to fire off. Then deeper in the skin are some other receptors, these ones called Ruffini corpuscles. Actually, not much is known about them, but they seem to respond to tension or stretch of the skin. And then these ones at the bottom, Pacinian corpuscles, these ones are deep. They're rapidly adapting. They can respond to frequencies anywhere from around 10 hertz up to 1,000 hertz and do it faithfully. So they're extraordinarily sensitive to vibration. And so those are 4 to kind of keep in mind, and we'll just move along here. Now, this is a terrible figure, actually, but because it's got the relative size is wrong. But in muscles, there might be, say, 100 motor nerve fibers going to a single hand muscle, but there will be as many as 50 or 60 receptors in that muscle that are sensitive to the length of the muscle and the rate of change of that length. So if it's shortening or lengthening and just its static length, that's information coded in the muscle spindle. This is not information that kind of comes to your head. If you did anything to this, you wouldn't have any perception of that. So this is an unconscious sensation, and yet absolutely vital. And I told you earlier, the sensory information from these fellows are right adjacent to those large pyramidal cells in the primary motor cortex. They're really quite closely related. Now, what about hairy skin? Hair, you probably, I don't know whether you've ever tried this, but I've done this many times. If you just pick out a hair when you go home, if you touch a single hair, you will know it. And you will know exactly where it is. They're very sensitive to touch. And if you look at the base of the hair, there are special receptors at the bottom. But if you think of the hair as a long lever, kind of bending or distorting the mechanical receptors that wrapped around the base, it's not hard to understand why you can pick up the stimulus to a single hair. So that's really quite extraordinary. Now, it's a little something about the responsiveness of receptors. Now, if the top here, you turn on the stimulus here, you keep it steady, and then you stop it here. If it's a rapidly adapting one, as soon as you stimulate it, you get burp, that's it, and then that continues. Nothing else, and then it only bup when you stop. So it start and stop, gives you start and stop information. A slowly adapting one continues to fire throughout the time that you're actually stimulating. And you could begin to think about the relative value of those to the central nervous system. And I put this together as a kind of simplistic one and organized them into kind of 4 groups. But at the top, where those Merkels are, those Merkels and Meissner's corpuscles, they have very small receptive fields. Some of them are rapidly adapting, others slowly adapting. But the important thing about them is they're very exquisitely sensitive to touch, and they have very small receptive fields. And then I mentioned the deeper ones, the Pacinian corpuscles, the Ruffini ones. They have very large receptive fields. The hair follicle, we just talked about. Muscle spindle, depending on, I'm not going to get into the detail of the muscle spindle, but one of my early colleagues at Oxford spent his whole career on muscle spindles. By the way, interestingly enough, there are no muscle spindles in the facial muscles. None. The hair muscles under the most rigorous control here for gesture and for speech, facial expression, all that kind of stuff. There's no feedback from the muscles themselves. Isn't that an interesting evolutionary choice? And we won't go through their kind of central pathways, but just if this is the primary motor cortex, area 4. There are muscle spindle projections to it in 3A and 3B. So the input from the spindles, those muscle receptors measuring length and rate of change of length, are immediate neighbors to those pyramidal tract neurons here. And then this is the Merkel disc and the Meissner corpuscles, the light touch, discriminative light touch is here, and so on. So each has their own area of the cortex that they project to. Now here's what I really like. This is a message right here on Braille. Here's the Braille, A, B, C, and so on across here. And then the subject was asked to run the finger across the Braille. And now you look at what the responsiveness was, or the responses of 4 different types of receptors. And look at the Merkel's discs. You could actually read Braille almost from this. It's quite faithful. And by the way, we're talking about one response from a single Merkel fiber here. There might be 100 of them in the flexor surface of one of these fingers, or maybe more. Meissner's corpuscles are equally discriminative here, but it's looks like a blurred image of the Merkel's disc. Ruffini, you have no clue what the Braille is saying, and the Pacinian corpuscle, not much better. So in reading Braille, these receptors, Merkel's discs and Meissner corpuscles that are in the flexor tips of the fingers, are really very important. Now, think diabetic neuropathy. Think of any peripheral neuropathy that impairs sensation. And as I mentioned in one of the earlier talks, it's length dependent. So the pathology begins at the extremity, meaning the receptor, and works its way proximally. So even if the parent nerve cell is functioning all right in all of its central projections, no wonder some people have trouble with light touch sensation. And no wonder blind people who are trying to read Braille would really be in deep trouble here. So that's one of the other slides. Keep in your mind, because that kind of very precise information is coded right out in the peripheral nervous system. The central nervous system really can't improve on this. If the messages come scrambled or impaired like this, they're impaired all the way up. So now here's one. I said stereognosis, that's the ability to discriminate, if I'm holding an object, a watch in my hand here, and can I tell with my eyes shut what it likely is? I call it the plumbers system, because I always think of plumbers working underneath sinks and they can't see what they're doing, but their hands up there feeling for the screw or finding where the screwdriver needs to be, or the wrench to put it on something. So, and that really does depend on Merkel's discs, Meissner's corpuscles, and these muscle receptors. And sometimes it also depends on the integrative functions this time around of the brain and the neocortical, in the neocortex, and especially the parietal lobe, because it's now integrating all of that information from these different receptors with memories of what different objects would feel like. Eyes shut, distinguishing the rayon from different types of material. And so some people are really very good at that. You could try that out with your eyes shut and see how well you do. Now, illusions. The sensory system, we can trick the sensory system. Remember I told you that the muscle spindles are very sensitive to muscle length and rate of change of length. So one thing you could do is borrow a vibrator that, the kind of thing that physiotherapists might use, and just apply it to the muscle. But then say to the subject, close your eyes. Now tell me where your hand is. And they'll tell you their hand is off in a space over here, or maybe even behind, in a place it could never be in nature. So all that incorrect information, or that messed up information created by the vibrating, has completely distorted the sense of where the hand or the arm is. So that's one of the illusions. So that's something I'm actually going to build on. There's another thing about this, and I call this making stuff up. One of the things I've noticed as a clinical neurologist over the years is that the people who have impaired joint position sense, meaning if I ask them, is your finger going up or down? And you can move up, say 1 or 2 degrees or 3, all of us should be able to pick up that amount, and with their eyes shut. And I might say, ask them to do it with their eyes open first, so you know that they understand what they're being asked. And then ask them to close their eyes. And all but a few patients with impaired position sense will make it up. It's a rare time that somebody will say, I don't know. They'll say up or down and say, well, gee, open your eyes, and does that make sense to you? No, 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 I understand. Well, let's go have another go. And then they'll repeat it. Now, it's a second part of this, expanding on that. There is a disorder called Wernicke-Korsakoff's disease. When this kind of thing was described, it usually applied to males who are alcoholics. But these days, with gastric bypass operation, some patients develop really bad thiamine deficiency and other vitamin deficiencies, but it's the thiamine deficiency that's the critical thing. And some of these people might develop psychosis, but those who are might also complain about their memory. That it can't make sense. And if you talk to them, you go into the room and you don't know the facts of their life, it all sounds very reasonable because it seems like a coherent story until you come back and ask it again. Say a few minutes later or half an hour later, and then the stories change. And one of the observations made, about 20 years ago about this was that these are people whose memory is really very impaired, but there are islands of memory that are true. And the patients are stringing a story together. We are all storytellers, as Robin Dunbar is so fond of saying. Humans, it's one of the defining characteristics of humans. We love to make up stories. If we didn't do that, there wouldn't be any theater and or writing, right? We like stories, and then in COVID times, we're watching it all the time. So we are story watchers and story creators and story embellishers. But pathologically, in this case, with Wernicke-Korsakoff's, it's really very obvious and called confabulation. And that gets into the storytelling, as I said, or mentioned at the bottom here. And that is something that, as Robin Dunbar pointed out, and Richard Leakey, that humans go one step further. They are quite capable of creating virtual worlds. Well, you know that to be true. We have talking animals and all kinds of stories. The library is probably full of that in the children's section, maybe some of the adult stuff. So we are comfortable inhabiting that kind of world. And that might actually play into some of our belief systems too. So that'll be something that we're going to deal with in the sixth one. Now, the other thing that, we don't know what we don't know. Some of you may be aware that that when you look directly at somebody, that the fine grain part of that picture is only within the central 20, 30 degrees. Outside of that, almost no color, and all you're picking up is movement. I notice that, but I'm sitting in the backyard kind of writing, sitting in a chair, and when a car goes down the street or the block beside, it always catches my attention in the visual field because of the movement, but not because of anything else. It's the movement I pick up. But moving in, if I look, and you could try this out at home, if you look directly at an object and bring your finger in to map your own visual field, you can map your own visual field, lower and lateral and medial as well. But one thing you'll also notice, if you do it very carefully and you keep your eyes focused directly on one spot, that tip of your finger will disappear at one point and then come back. That's your blind spot. That's where the optic nerve is actually penetrating the retina behind, and there are no visual receptors there. But you don't know that. But you actually have a blind spot there. So, and of a different nature, very early in my career, my father had, I think I mentioned this in one of the articles, but my father had an ischemic stroke affecting his parietal lobe on the non-dominant side. And this had some rather peculiar effects. One of them, I remember we had a schoolhouse up near Meaford, and we went for a walk, and several of us were going over a fence. And Dad was fine. He got his right leg over, and then he got hung up. And I turned around and said, "Gee, Dad, what's wrong?" And he was looking he looked very perplexed. And because the left leg didn't belong to him at that time, he really forgot how or out of state or didn't understand it. When I said, "Dad, if you could just lift that left leg and look right at it, lift it up," he was fine. But then he repeated the same thing about 15 minutes later when we came back crossing the same fence. Also, I remember at the dinner table, he would eat all the stuff on his right. And his second wife then would just kind of, without saying anything, just turn the plate. So that sensory inattention is really very striking, and it's a characteristic of the non-dominant hemisphere. And sometimes to the point where if you hold somebody's hand and arm up or their leg up and you say, "Whose arm and leg is that?" "I don't know." Well, could it be yours? And then kind of a pause. Yet they can use it, except as Dad did with the fence. So this is all getting into the business next week of what we're aware of, what we're conscious of, and how information is handled in the nervous system. Now, here's one. Oh, by the way, this is a this is the monkey here, and who's been trained. There's the hand. By the way, what do you? I hope you notice in that hand the difference between that hand and your hand. The thumb is just like another digit. It's not partially rolled over or opposed onto the other fingers. And relatively speaking, it's a lot shorter. That's an evolutionary change, a big difference between them. And but this particular monkey was trained to use, the index, the middle, and the fourth fingers a lot in a kind of repetitive task. And then they mapped the sensory area related to those digits. And with the result that after the training period, the expansion of, you can see, well, here I've got this little thing. So here's 4, the fourth digit here, the area of the cortex that finger maps for, and the same one here, and for the middle finger here. So 3 and 4 are enlarged, and look at 2, the index finger. So they've all expanded. And if anything, 5 is contracted. Nothing has anatomically spread here. These expanded areas have no more nerve cells in them than they had before. But all of these nerve cells have multiple, they're talking to a lot of other nerve cells. And the relative strength of those connections can be changed with training. Remember on the motor side, I mentioned that piano players, that the areas of the motor cortex and premotor cortex related to the fingers, that would be forearm muscles and intrinsic hand muscles, actually expanded and became thicker. Again, not because that area of cortex has acquired any more nerve cells. It's just, it's acquired richer connections and stronger connections. And that shows up in fMRI pictures or PET scan pictures, or if you map the cortex with microelectrode recording. So, so this is an interesting one. Now, here's one that what's happened here is that the middle finger, for the purpose of the study, was amputated. So what happened to the sensory area that would normally have been occupied by that middle finger, number 3? So there it is before, and over here nothing. So the adjacent ones have filled in. There isn't a kind of a vacuum there anymore. They've filled in. Again, it's a matter of strengthening connections, pre-existing connections that were subliminal before, and now strong enough that it actually shows up in a mapping program like this. So, in fact, some of these expansion and contraction, apparent expansion and contraction of maps, can happen within hours, which clearly shows it's got nothing to do with the number of nerve cells, but it does have something to do with the activity of those nerve cells. So now we come to pain, and Ron Melzack, McGill. So those of you with a Montreal connection, this might resonate with you. There's a bit of a framework for this. One of the things, one of the mysteries of on the battlefield sometimes is that, or even severe civilian injuries, sometimes noticed in emergency rooms, the people who have severe wounds might have no pain. Nothing. If they're conscious, sometimes walking. You see some of that in the footage from the landings in Normandy. A little gruesome, but somebody climbing up the beach and without an arm. But so some of the most horrific things, and for a temporary period, and surgeons have recognized this, that's almost a magical period to do something, because you're not going to need morphine or put them asleep. I don't know what that's all about, but I don't think it's got much to do with this subject, but it is an interesting one. But another observation that does was made in the American Civil War, that somebody had an injury, say affecting the shin, whatever that was. It helped sometimes to rub the skin in the area, that they could abate or help or ameliorate the pain somewhat. Now, if you think about what they're doing, if you're stroking the skin, what are you stimulating? You're stimulating large myelinated touch pressure receptors. Maybe some of those were Feeney guys. That's what you're actually stroking. Pain fibers are very different. They're unmyelinated. I mean, some of them have no myelin sheath, and the others very little of a myelin sheath. So they're actually very different populations of nerve fibers. So this led to Melzack and Wall. Wall was the mentor for Melzack. There's this gate theory of pain that came out in, I think, the 70s or 80s. Anyway, and got a lot of attention. Led to one famous textbook on pain. You can see it right there. That's actually a worthwhile thing to talk about in session, maybe next week or the week after, because of some of Melzack's observations. Anyway, we'll get to that later. But the whole idea here was that these pain fibers Once their threshold is exceeded, the impulses travel up to into the spinal cord and then through a series of connections to the structures in the brainstem and in the thalamus and to some extent in the sensory cortex. But one of the things about the sensory system and the motor systems is they kind of keep track of themselves. So on the sensory side, yes, there's a lot of information going up to the sensory cortex, but there's almost twice as much information coming from the same cortex back downstream to kind of monitor what's coming in, and sometimes gating it or effectively blocking it. And that's what the gate theory of pain was all about. Meaning, if by stroking the shin, and I stimulated some of those larger myelinated fibers, can that input actually damp down the input in the pain fibers coming into the spinal cord? And experimentally, yes. And so that led to this gate theory of pain and the development, for example, of stimulators, dorsal spinal cord stimulators, and as a trial to see whether that diminished pain in people that, at least to help them where medication wasn't helping. So I don't say it's definitely not as simple as Melzack and Wall thought then. But here's the diagram here, because here's the large fiber, the input coming from touch pressure along the shin here, and it comes in and it heads up the back of the spinal cord. Well, you know that already, but it also sends branches to smaller nerve cells, kind of neighborhood nerve cells, and some of those neighborhood nerve cells actually connect to the incoming pain traffic and can actually block it. So that's theory, the diagrammatic, and it may well happen at multiple levels. Now, pain has I'm oversimplifying for this, but pain comes in basically two forms: the sharp, stabbing, sharp pain that's often quite well localized, and this is carried in small myelinated nerve fibers. But then there's another type of pain, and that's a kind of a deep, boring, aching, really uncomfortable, hard to localize pain sensation. And that almost universally is carried by fibers that have no myelin sheath. Now you see the difference here, because here's the stimulus, that little blip up, beep, 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 so on. The pain, the temperature receptor here, as the light bulb, the intensity of the light goes up and it becomes painful here, and the recording from one of these single nerve fibers here, as you might expect, as the temperature went up, then the number of bursts, the frequency of the bursts, the duration of those bursts increased. Okay, so in other words, the output signal from the nerve fiber is proportional to the intensity of the stimulus. That makes sense. But the pain receptor has a much higher threshold here. And it's only at the highest threshold, when the temperature is really uncomfortable, that it starts to fire. So, and I've already mentioned, by the way, that dull, aching, boring pain, when I was in London Health Sciences, we borrowed a technique that several people had developed in Sweden, which is very elegant, because it's very hard to assess sensory function in animals, because they can't tell you what they're feeling or where. The humans can. So what they developed was a way of recording from single sensory nerve fibers in, say, the median nerve or the ulnar nerve here. And that's how all of that information I talked about of Merkel's disc, Eisner's corpuscles, all that kind of stuff was actually worked out. by these groups in the 1970s, 80s, and into the 90s. And it's great work. But in the process of that, I do remember, because I was often, if you're in a lab, part of the culture is that sometimes you're the one being experimented on. And that was my turn. And I do remember that tungsten microelectrode entering the nerve trunk, and for the most part it was fine. And then there was this really disagreeable, dull pain that even the microelectrode might have been occupied a space of maybe 5 microns, but the pain felt as if it was coming from the whole of the forearm and even into the hand. Very uncomfortable. And that was kind of a lesson for me, not to not do it again, but about what happens to those nerve fibers. Now, what about pain from our gut and our viscera? Well, it's mediated by or similar naked nerve endings, small myelinated fibers or unmyelinated fibers. That's true. But one thing that distinguishes visceral pain is it actually goes up the dorsal column, the back part of the spinal cord. And so one surgical technique that was developed, and furthermore, not only does it go up the back part of the spinal cord, but very conveniently, right around the middle, the paramedian area. So if you put a needle in there, you can lesion that area, and it works sometimes. Pain is a very difficult thing to manage in my experience. Now, sometimes pain is referred to other places, and I think any one of you who has had kidney stone, as I have had, that kind of thing, realizes it's right around the costal margin at your back, and then around in the round of the groin, so sometimes, I mean, patients with visceral pain often won't tell you the way they will with a skin lesion or something in their muscles, that they can point directly to it. Oftentimes, the pain doesn't seem to be directly, at least anatomically, connected, but it is referred pain. And it relates to the fact that in that same area of the spinal cord where the signals are going in, some of those sensory fibers, for example, are sensory fibers from, let's say a C6 nerve root entrapment. And somebody might report, well, they've got pain in their biceps reach, and then some of them will tell you, gee, it seems to involve my chest as well, and even over my back. What's in common between all of those? The same root territory, C6 or C6 shared with C5. So sometimes you'd have to pay a lot of attention to where the referred pain is if you're going to figure out what actually the cause is. So that's the only reason why I put that one up. Now, just a word about the placebo effect, because this is really an extraordinary thing. I'm sure many of you know about this, but there was that classical medical student study in which healthy students were told, one group, that they were going to be given a sedative, and another group were told that they were going to be given a stimulant. They actually got nothing. They got a placebo. And interestingly enough, 70 to 80% of those who were told that they had a sedative felt sleepy. And those with the stimulant, that they had energy and more zip. And there is the even better study, the postoperative study of postoperative pain treated with saline. And it certainly is very effective, 70 to 80% of the time, to treat somebody. Tell them that somebody that, look, I'm infusing this. I think within a few minutes or so, you should begin to feel some improvement. It should kind of settle down. But the trick is, or the thing is, if you give those patients naloxone, that effect is gone. What's that tell you? Well, naloxone blocks opiate receptors. And the brain has a lot of opiate receptors in the spinal cord, in the brainstem, even right up to the cortex. So, and naloxone can block that real effect. Then there's the, maybe just in the interest of time, I won't get into the Zamboni effect, but faith healing. I've had several patients, mostly from the Thunder Bay area. I don't think the regional thing has anything to do with it, except larger numbers or a larger proportion of Aboriginal or Native peoples. But some really the first one I remember was a very earnest, hardworking person, and held down a full-time job, but a lot of pain, and was on multiple medications, and horrors of horrors, had gone to 2 pain clinics without much result except to be put on more medication. And somebody suggested you should see a faith healer in Quebec, north of Quebec City. And she did. And she got my phone number and phoned me, and she said, "You won't believe this. I was hesitant to tell you this. I wasn't sure how you take it. But that's what happened. And the pain all went away. And I could tell you that she went back to the job. She was off all of her medication, and it lasted for almost a year. And then I got another phone call because the pain was coming back, and she asked me, she said, "Well, Dr. Brown, what should I do now?" I said, "Well, we both know what actually worked, and we also know what didn't work. So I would go back again," and it worked again, not as long. And then tragically, the third time this happened, the faith healer retired. Now, I can count them on the fingers of both hands with a couple of fingers left over of similar accounts, which to me make sense. They're mysterious. I don't understand what's going on, but I've learned to not be judgmental about it. And just let things go, because there's a lot we don't understand about pain. Now, I'm just going to finish off here. There's more stuff, but perhaps we show this, but some of you know this series, The Ascent of Man. And he has this remarkable capacity to bring the arts and sciences together. I mean, they are as one. He inhabits both worlds comfortably. And in the Century one, there was a remarkable image. It's in the last one, or second last, or maybe the last program. But there's an image of this fellow. He looks this early 70s. We learn from Bronowski, he's from Poland. Good-looking man, and a young woman who's blind comes into the room, and she's asked to explore him, to tell him and others what she thinks about this man. Never met him before. And so she explores his face with her hands, using all those Merkels and Meisner's discs and all those length-dependent kind of things. And she said, "Oh, and also the skeletal features." And she said, "Well, it's a man. I think he's probably an older man. I'm pretty sure, just because of the skin and the folds and that kind of thing, the nature of that." And then she said, but it kind of stuck with me. She said, "I think he's Polish." And it was really based on really the shape of the skull. Now that sounds totally weird, I know, except there have been a couple of studies recently in Nature about skull shape, and to say Neanderthals have these longitudinal, flatter skulls, the larger kind of brow bone here, but it's the lower longitudinal skull shape. And that's present in Eastern Europeans in about 20, 25%. And one of the questions that came up in the Nature paper, well, we can map the genome, can't we? Do these people with these head shapes, based on CT scan material, do they carry, is there some, do they carry Neanderthal genes that might somehow influence their skull shape? And the answer was maybe. I mean, good enough that it got into Nature. So I thought that was an interesting observation. And so I'm just going to see. We're not going to get into memory here. So that's my wife and I, and in better times with our airplane up at Peter Castle sent me that picture the other day. So anyway, so if there are any questions, I'm happy actually to talk to people on the phone too. But now let's see what we can do. Okay, all right. So any thoughts? Now this is a bit of a provoking talk, I know, but it's deliberately that way to run into the one on consciousness and then the later one. So any thoughts or things that you'd like to comment on?
How about hypnotherapy
Oh, hypnotherapy.
in the line of faith healing?
Elizabeth, you're talking to probably the wrong person for that, because I really don't know what it's. So I hesitate to say anything about it. But there is a power of suggestion for sure, and I when I was in Thunder Bay, I looked at with one other person, looked after 1,500 patients with multiple sclerosis. And we went through a very awkward period because an Italian surgeon decided that the pathogenesis of MS was related to blockages of veins.
Oh, yes, I remember that.
And so there were all kinds of, the CBC made a mess of it, the television, and the Globe and Mail, and it was kind of a Canadian phenomenon because you went south of the border, it was almost absent. But anyway, the point I'm saying, these are people I knew well. I'd followed them for a long time. They were desperate for something to happen, and they would come back from the Caribbean, from Poland, from India, after spending many thousands of dollars. Often the community would raise a lot of money for them, and quite convinced that they were better. See, doctor, I'm walking much better. I can get out of this chair. My balance is better, and all this kind. And my attitude was I encouraged them, but not. If they asked me, what did I think? Should they go and have this stuff done? I said, look, as far as I could see, there are risks to this, and there's no evidence actually that supports that. It turned out I was right, but these were sensible people. These weren't nuts or crazy people. These are sensible people, and dealing with a very difficult problem, and some of them were very convinced that they were better. Well, who's going to knock that in a way after it's happened? Not me. There's no rewards for that kind of thing. I didn't encourage them. I held several large meetings, community meetings. There might be 200 or more people at these meetings, and they come from all the towns along the Trans-Canada, as well as in Thunder Bay. And my sense is, if you're honest with people and that's straightforward, tell them what you actually think about things, people are pretty good.
Hmm.
And so getting back to the hypnotherapy, if somebody came into my office and said, and I knew something about their story, and then I found out that this, like the faith healer, I found out that it had worked. Well, I don't know. I'll tell you one thing I definitely know for sure that I know about the brain and the nervous system is there's a lot more than I know about the brain. There's a whole lot of stuff going on there, and we're barely touching the fringes. And if you look at the research that the solid stuff, the Nobel stuff, it's all been peripheral stuff dealing with end organs, the vestibular system, or analyzing memory in detail, as Eric Kandel did, or looking for position cells in the temporal lobe. Stuff that's can all be handled experimentally. But getting into like next week, consciousness, well, you'll see the great divide next week. And then the week after is a whole other one, because then we get into this whole storytelling business, which does seem to be very central to the human experience, and so widespread and so much a part of the human character that you have to think that there was a lot of evolutionary pressure to conserve it, or maybe even develop it. So anyway, I don't want to give away anything, but
Dr. Brown?
I haven't answered your question, but yeah.
Dr. Brown, there's another question. Pamela, do you have a question?
After the last one, are you kidding?
Okay, hi.
Yeah.
Okay, it's sort of a two-part. In the monkey studies you were talking about, when there was specific exercises that they were having the monkey perform, you saw that there was a larger area of the brain that was taken over by the digits that were being used. Conversely, when they removed a digit, the other digits absorbed the space that there was before. Then last week you were talking about a piano player and the amount of space the hand takes. Drawing on those analogies, if an individual, whether it's a golfer or a tennis player, if they're doing repetitive work, and people talk about takes 10,000 hours for mastery, does that increase, and can you increase the mental map of a particular part of the brain by repetitive exercise? That is
That's a really, really good question. And thank you. There are reasons why studies like that at the monkey are done, where you have a really specific, definable task. If you're asking a question about something much more complex, more, say, maybe complex movements or maybe behaviors repeated enough times.
right.
Yes, I think there's I use this word a little loosely, but I think the nervous system adapts and remodels. If we think about if we go back to our earliest development from that single cell, and while we're laying down, I mean, yes, there's a genetic template for sure, but it isn't long before the environment and what goes on, what's going on around them begins to shape the destinies and the connections and the relative strength of connections in those young brains. That's never, I think, entirely lost. That's probably something like that is in play here. Now, what the difference is in infancy is it probably at that stage, it actually can influence the number of cells. It certainly affects their connectivity. And it would, and I would think right into late adulthood where I am. I think that kind of remodeling takes place, but it's probably not as localizable. In answering to a question like you, I think about somebody like Roger Federer. Okay, he's my hero, right? So somebody serves. It's somebody he knows from before. He's Nadal.
Yeah.
Has played many times. He knows kind of what to expect. Maybe not quite that day or that game or that set, but he's a lot of experience with Nadal. He knows, he's familiar with the serves. He's learned to read them, and he already has long-standing templates for different situations. I mean, somebody like Roger or us, we don't think, we have our eye on the ball. We're not thinking where our legs should be. We've been taught that. Experience has told us how to move most efficiently, laterally, forward, back, all those kinds of complex movements, all integrated with the trunk and head movements, eye movements, all that kind of stuff. That involves so much of the nervous system that I would think those skills, if there's any remodeling taking place, and there almost assuredly is, it's taken place at a lot of levels. The neocortical level, the frontal level, the level of the basal ganglia, for sure the cerebellum. Cerebellum plays a huge role in this in so-called motor memory. And so does the secondary motor area, where kind of I think of ballet dancers here, where it's a kind of a routine, a certain routine, certain steps, and they learn them, and the dancer's no longer thinking about the step, where this foot is, or this leg is, or arm, or that kind of thing. They're thinking about music, and they're thinking about the choreography, if even that. And this whole thing unfolds. It's been stored in so many areas. And furthermore, it changes on the fly. Just imagine Roger running. Djokovic sends a drop ball. Roger's not expect that Roger would anticipate everything, but let's say he didn't. And a drop ball drops, and suddenly he has to adjust and change. He's still not thinking about, oh, my right arm, this how I have to hold the racket and all that kind of stuff. He's still got his eye on the ball. The rest of it is on autopilot. I think most of the nervous system is on autopilot. I think we're barely aware. This gets into next week. We're barely aware, just a tinge of the stuff that rises the threshold. The rest of it is all on autopilot, and that's where training comes in, doesn't it? For all athletic events, I think, and for the daily routine. So yes, so you say, you're really asking, does the brain remodel? Yes, for sure it does. And it also loses some of that training effect when we stop. And so it's really important to keep going, especially when we're older. I don't know if I totally confused you, but
No.
okay.
I have.
by the way, that was a kind of a favorite question, at least in the years I was in London, on PhD thesis things. About, describe what happens in the brain in catching a fly ball. Tell me what happens. Well, no one knows what actually happens, but tell us from what you know. Forcing somebody to pull the material that they've learned in bits and pieces into a coherent story. Kind of motor novelist, so to speak. So anyway, anything else?
Anyone else have a question?
Okay, that means they know everything. So next week, consciousness, and that's like an inverted bowl. We're going to start out with a pretty elemental stuff, and then move from there, because that really informs the sixth one.
Okay.
Right?
That's awesome.
That's where we're going, I hope.
All right, everybody.
Okay.
Thank you, Bill.
Done?
Okay, thank you.
Thank you, Debbie.
Thank
Thank
you,
you.
David.
Okay.
Everyone, and go enjoy the weather. We'll see you next week.
Yeah.
Okay.
Okay.
Bye-bye.
Bye-bye.
Bye.
Bye.